Hi, it's Ben Spiro here from accuRx, and today we're going to be covering lessons learned going live with Patient Triage. We're joined today by David Coleman from Conisborough Practice, who's been live with Patient Triage for about 2 months, to share how he felt before going live, what that go live process looked like, and lessons he's learned along the way. For those unfamiliar with accuRx Patient Triage is accuRx's online access solution where practices can put a link on their website and let patients fill out a short admin or medical request. This can be really beneficial for practices since it cuts down on phone queues and allows for a more controlled process with consistent decision making on patient outcomes. It's also really great for the patient because it can avoid phone queues. While as a product, Patient Triage looks and feels quite similar to the rest of accuRx in terms of using the inbox and the integration with the patient record. We know that the implications to it are very different, especially how busy general practice is at the moment, and that it brings new and valid concerns. So we've set up this webinar so that practices can share their stories of going live, the concerns they had, the decisions they made while implementing, and the lessons they've learned along the way. It's no exaggeration. So I've been looking forward to this webinar for pretty much all week now. We're joined by David from Conisborough Group Practice, who went live with Patient Triage, I believe, a couple of months ago. We've got a few questions for you, David, but more than anything, just a chance for you to share your story. So thanks very much for joining us.
Thank you. Yes, I'm a GP partner at Conisborough Group Practice in South Yorkshire. We've got 11,500 patients, so fairly large suburban practice. Do you want me to just tell a little bit of the background and explain what our position was when we started, what our plans were and how they changed and how it all worked out, and then ask some questions? Or do you want to ask me some specific questions first?
The first one I had down was exactly as you suggested, just setting the scene a bit before going live with Patient Triage, what that was like, and then what led you to give it a go.
Yeah, certainly. Okay, so yeah, as I said, sort of medium-sized suburban practice in Doncaster. We'd been using accuRx throughout the pandemic, mainly for SMS messaging, for things like skin rashes, send us a photo back. We'd use it for sick notes, and we'd started using it for Flories as well, for recall. But when we were informed that our CCG was going to fund all the practices to have use of the Patient Triage, I think I didn't, but some of the other partners had some reservations, and there was a little bit of anxiety about, will this open the floodgates? What may we be unleashing if we put a link on our website and let people contact us? So that was the point we started at in the summer. I wrote a plan for how I thought it could be integrated. And we had a few back and forth discussions about that. And the things that were coming up is, will we be overrun? We've heard horror stories about people using other digital triage systems and not being able to turn them off and coming in after the weekend to hundreds of requests and suddenly feeling like they were drowning. Will it be equitable? If patients who can't use it, will they have the same offer as people who can? We didn't want, for example, elderly patients who didn't have access to digital technology not being able to get appointments because all the tech savvier patients had snapped them all up. So that was a concern. And then I think also, just given how exhausted the workforce has been after the pandemic, just another change really. I think there was not a great appetite for embracing a significant change in the way we worked. So the easiest thing to do is to kind of kick it into the long grass and kick it down the road a little bit. So that, in a sense, is what happened for a month, much to my frustration after I'd written the plan. But we came back to discussing it and we decided we really must give this a go. So the plan was tweaked, and what our next step was to look at just doing a very soft launch. That was the buzz phrase we settled on. So rather than put a link on the website and open it up in a bigger way, what we decided would do is, just to get a feel for the program and how it worked, we would offer it to a small sample of patients who phoned us up as an option. So they would call us up and say, I want to speak to the doctor, I've got a headache. And 10 patients at random would be invited to fill out more information about their problem through the website, with the guarantee that they were on our list and they would be dealt with today. The goal was really for the clinicians to get used to the system, for seeing what the information gathered looked like, and think about how the flow of that works. You know, do you manage that by phoning them? Do you manage that by sending them another SMS message and having a conversation that way? Do you launch a video chat as a result of it? How do you allocate it? Does the duty doctor do it? Do you share them out to different clinicians? So we thought we'd dip our toe in the water and try it. What we found was that it didn't really work that well doing it like that. What we were doing was trying to kind of force the patient triage option on patients who had used the telephone, who already knew they were on our telephone triage list as a backup, and that they would be getting a call anyway. And what happened was we had about 20% uptake of responses. So the soft launch, the initial conclusion was people don't seem to be that interested in this. They like our telephone triage system for all its challenges getting through at 8 o'clock in the morning. And they find it a bit of a faff filling out online forms and really just want to speak to someone. So we thought, well, maybe that's it, but maybe it's the way we've done it. Maybe we've targeting the wrong people. What we did find is that the 20% of people that replied, the quality of information was excellent. We were getting a much better history with respect to the receptionists. We were getting more information than the receptionists documented and extracted. Often we were seeing that we had enough information there to decide where this patient needed to go, whether they needed to be signposted to another service, or whether they would be better fitted in with a pharmacist or a nurse practitioner, or that looks like a good case for a GP trainee to see. So rather than our telephone list that just said headache, abdominal pain, tired all the time, we were now seeing a little bit more, and we were able to determine pretty much what they needed. Also, the other thing that was really useful was the patients were telling us what their expectation was as well. So people were saying, I really want to see Dr. Coleman face to face. I'm really busy at work. I'm hoping I can be dealt with over the phone. You know, I only need a sick note. Could you send it to me over accuRx? So we were knowing what was going on and also what they were hoping for. Now, sometimes what they were hoping for was unrealistic. You know, they had severe abdominal pain and wanted it to be dealt with over text message. Whereas obviously that's the kind of problem we'd want to see face to face. But for 70-80%, the mode that they preferred was in line with what we felt would be the best option. So we carried on using this sort of sampling system for a short while, and the plan was to kind of review it at the end of a month. But unfortunately, other events kind of forced us to change our path. At the same time, because of our challenges with people getting through on the phone in the morning, we had expanded our telephony system. We'd moved to a new cloud-based queuing system to try and improve phone capacity. And it just ended up being a complete disaster. The patients kept getting booted out of the cloud queue and being lost altogether. They were sort of put into endless loops of queuing, and all of a sudden, rather than getting 10 accuRx triage requests, we were getting 10 one-star reviews on Google, complaints coming in left, right, and center, and just the receptionists, when people did get through to them, were getting hammered with a stream of abuse. It was just a really terrible time. So, having had accuRx in the locker and having kind of tried this soft launch, we thought we've got to do something. We can't suddenly change our phone provider and solve this problem. We have to try and work with our provider to improve it. But that's going to take weeks. We thought, well, the one thing we can do is we can just open up accuRx Triage and just go with the initial plan, put a link on the website, signpost our patients to it, send everyone a batch SMS saying, please use this service if you can. And that's what we ended up doing. We went from the soft launch to just diving in at the deep end, because the alternative was just keep getting hammered with complaints and abuse. So that's what we did. And we found actually that it really worked in that situation. Diving in there and just throwing it out there seemed to actually be quite manageable. First day we got about 15 requests, second day about 25, and then we were up to 30 or 40. And we've hovered around that area since then. We found that the requests came in pretty much the same sort of timing as our phone requests. Most people, I think they're conditioned. If you want to deal with the doctors, you contact them between 8 and 10. If you want to be dealt with on the same day. And that's what tends to happen. We get also admin requests on there, people with prescription queries, people asking about COVID boosters or flu vaccinations and things like that. Now, what we tend to do, obviously, demand is difficult to predict, and sometimes your staffing doesn't necessarily meet what you can offer. So what we tend to do is once we get up to around 30, 40 requests, we'll tend to close the medical request side of things whenever that happens, and open it up again at 8 o'clock in the morning, which is mirroring what we would do for non-urgent things on the phone. But we always leave the admin queries open so that if anyone needs to contact us about a letter or to chase a referral, we can still receive those requests and someone will assign them to the relevant team member, really. I think the crux of what we've learned is that fear of us being overrun wasn't really that well founded. I guess the number of people who are out there on your patient list who are going to try to make contact with you on a given day is finite, and there's a risk in not engaging and speaking with those people and finding out what's going on. What this does is gives us a quicker overview of what that demand is and who's best placed to deal with it. And I definitely feel that I can deal with 30 accuRx Triage requests in about the same time that I can deal with 15 telephone requests. It just ends up being more efficient. So that now when we're being told to step up the boosters, we tend to find that actually we'd like an even higher proportion to come through accuRx, because it will just make our process that much more efficient when our capacity is reduced a little further. So yeah, if I've missed anything, that's sort of where we're at the moment. If anyone wants to ask any questions or tease out a bit more detail, please do.
Thanks very much, David. And yeah, everyone who's joined as a participant, please do feel free to type your questions in the chat there, and we'll make sure David gets through to them. David, if I can start and just kind of teasing out a bit more of that detail, there might be some practices in the call who don't use online access or maybe don't use it, they're not actively pushing it out to their patients. You mentioned in that planning stage, you had that plan going out and then drafted up, and then that soft launch, and then sort of diving in the deep end. When you were first getting started with planning out what this might look like for your practice, were there any sort of resources or ways of thinking that you found especially helpful and would recommend to other practices?
Yeah, that's a good question. I think I tended to use the experience of what I'd of using accuRx SMS as a kind of as a starting point, and I kind of I think at the very beginning I'd started writing the plan, but then I did come on. I had myself and the practice manager had a webinar with someone from accuRx, which provided a little more detail and helped us kind of hone in the plan. Because I think initially we were thinking, how are we going to, say we get 30 requests, who's going to do them? You know, can you assign them, or do we just work from a list? Do they come to an individual's inbox, or do they come to a shared inbox? So these were the kind of unknowns, really. So what we learned, obviously, was that they come to a pooled inbox, which is great because it doesn't rely on, it doesn't fall down if the on-call doctor is sick and it suddenly has to change. Come into a pooled inbox, you can control who has access to that pooled inbox. So we have that for all our partners and salaried doctors at the practice who can see that. We have a couple of receptionists who have access to it as well, so they can help with some care navigation. So that webinar that we attended was useful in kind of teasing out some of that detail. I think another one of our queries early on was, at the time, there was a lot about mapping our appointments and mapping our activity to the NHS England sort of appointment types. Obviously, that sort of, the rationale for that became evident when we were sort of hit with that data from August, which was sort of slightly questionable data quality, looking at practice activity. And I think we had a little bit of a concern, what if we do all this activity in the accuRx system and it isn't logged on our clinical systems? When NHS England do a search, it will look like we haven't done anything. So that was something else I built into the plan, that when a query comes through, we will book it onto our clinical system into a triage slot, just so it's clear for anyone doing any data extraction that activity has taken place. So that was another thing we built into the plan. So that was it. I think I'd looked at that. I know there are some other good resources. There's various GPs and things on social media who do quick overviews of clinical systems and tools. I think I'm pretty sure I watched some YouTube videos about other people who were using it, early adopters and stuff, and teasing out some learning from them.
Thanks very much, David. And we've got some questions coming in from people who are listening to the webinar. So I'll go through some of these. First is a kind of a clarification question. Could you go through again what exactly you do with urgent clinical, hi David, please could you clarify what you do with urgent clinical requests after 10 a.m? Yeah,
so basically our phone lines are always open until they close, and if anything urgent comes in on that, they'll be conveyed to the duty doctor. The accuRx Triage has a built-in sort of message that basically says, if you have chest pain, difficulty breathing, any of these kind of emergency type scenarios, don't use this. It's not for that. We have clear signposting on our website as well, that if you have any of these medical emergencies, not to use triage or rely on the surgery, but to seek help. If the system's open and medical requests do come in, sometimes patient, with the best will in the world and putting the warnings and disclaimers on their patients, will override it. So we have had people who've obviously clicked past that warning and then entered, I've got chest pain. Because they're coming into a pooled box, we are looking at them pretty much constantly throughout the day anyway. I've in fact even had a couple where people have shoehorned a medical request into an admin query as well, which is a little bit either naughty or they haven't read it properly. But I think it's pretty clear that you're not supposed to do that. Everyone who submits a request through our system, you can set a default message. So the message comes up that the response time for these queries, we try to deal with them on the same day, but the response could take up to 3 working days at busy periods. So if your request is urgent, please consider contacting the surgery. It's just there as a little bit of a disclaimer in case we overlooked something. But generally, if it's open and someone puts a request in that isn't a medical emergency but may be urgent, I don't know, something like, someone who's febrile and urinary symptoms and some abdominal pain, the sort of thing you'd want to see on the day, we would contact them and get them in. I guess because they've submitted the information, you've got a better chance of knowing that than if the receptionist gathered that information. So that's kind of what we do, really. Does that answer the question?
Yes, I certainly think so. Thank you very much for the detail there, David. A question from Anita. What's the capacity per day for a GP?
It's a big question, isn't it? I mean, it's quite a philosophical one, really. I think we all probably feel like we're operating at beyond our capacity every day, don't we, at the moment? I think we've been doing sort of total telephone triage at the practice for about 7 years. So we've been doing it from before the pandemic. We don't use an equation so much as a kind of our intuition built up over 7 years of doing that as to what we can manage on the day. The first thing I do if I'm duty doctor is kind of have a look at how many hours of triage and how many appointments I've got. And then I'll make an educated guesstimate based on that. What I tend to do is sort of split our capacity at the moment about 60% telephone, 40% accuRx, and then make a judgment call as we're approaching that limit as to whether to slightly change the messaging and think about turning off the medical requests if we're in danger of exceeding it. But I think there's no hard and fast rules. Again, it also depends on the type of stuff you're doing, because if I get 40 requests on accuRx and 20 of them are things that can be signposted to other agencies. So we've got first contact physiotherapy, we've got an eye care service, minor ailments scheme at the pharmacy. If there are things that can be signposted to them, it's not stuff that's going to particularly affect our capacity for the GPs. So we can, in that case, allow a few more requests to come through. But if everything comes through that's going to be clearly stuff that we need to see face to face, the number of requests we can receive is going to be different. So what we tend to do, in short, is let the duty doctor decide what the capacity is. And we're moving more and more to a situation where the duty doctor doesn't really consult face to face, which sounds a bit miserable in some ways, and it isn't necessarily what we're trained to do, but that just seems to work best at a practice of our scale. So the duty doctor will tend to do a bit of supervision, but primarily have that oversight of the day, manage the capacity, and you're almost buzzing around the place like like a consultant on a medical assessment unit, doing a bit of troubleshooting, doing reviews, and just being plugged in and aware of what's happening in the day and where the capacity is.
Thank you very much. Question here from Yi. We're in a similar situation. We've been using a different online consultation provider, but are considering switching over to accuRx Patient Triage. We've been using SMS, Flores, pathways, and love the interoperability and user-friendliness. How much time do you allow your clinicians to deal with each request? And I'm assuming that these are instead of telephones or face-to-face, not in addition to the daily workload. We've been found that we've been triplicating workload, i.e. an online consultation leads to a telephone, which leads to a face-to-face, so it's not always as efficient.
Yeah, it's a really good question. I think what we tend to do, so how long does each request take to answer? I guess it depends on the request, and so you probably had the same sort of things with another provider. But if I look at the requests today, for example, one of them was, I want to speak to Dr. Coleman, ongoing headaches and tiredness. I know straight away that's going to need, it's an ongoing problem. It's sounding like there's a few issues going on. It's going to need a telephone consultation. So we tend to, really match the timing to the problem. If there's one on there where someone's saying, I've got a funny mole, I'm a bit worried about, here's a picture of it. I think someone will be able to deal with that in 5 minutes. But if it's someone saying, I'm really struggling to cope, it's going to be at least a 10-minute phone consultation or a face-to-face. So what we tend to respond to them in the way that the patient chooses where it makes sense. So if they're saying they want a text message back, we may have a conversation through accuRx, maybe ask a few follow-on questions if it's unclear what the best pathway might be. So often people will say, I've got a rash, but don't send a picture. So the first thing I would do for those as the duty doctor is very quickly reply as soon as possible in the day. We'll be able to help. If you can send a photo, are you able to do that? And then I'll move on to the next one and start dealing with that. And you've got to have a few sort of plates spinning in the air really to make it work. And then half an hour later, that reply might come through, oh, it's a rash. Now, I might not have time to deal with that myself, so I might allocate it 5 minutes for another clinician to do it. Or it may be such an awful photo that they're going to need a face-to-face. So I might reply and say, can't really make a decision from that. I'm popping you in for a 10-minute appointment with this person. Or if someone's saying they're depressed and they really want a face-to-face, I'm not very good on the phone, I might put them in a 15-minute appointment. Or, if they'd alluded to suicidal thoughts, maybe even make it a double appointment. So I tend to be guided rather than have a hard and fast thing. What we tend to do is that either the duty doctor looks at them all and allocates them accordingly to clinicians to deal with based on what they think is going to be needed. Or if the duty doctor's got a lot of other things going on or doesn't feel that they're that slick, we've got a couple of clinicians who find it really hard going and struggle to get through it, and they're not really that used to or keen on that way of working, and that's kind of fine really. So they might allocate it to someone who can work through them a little bit faster. But it's a good question. I think we've always had this mentality that before 11 o'clock we all just muck in and work through everything and try to get it done, and some people do work faster than others, but we tend to kind of just roll with that rather than be too prescriptive about how much time everything should take, and generally that works well. Sometimes it can be a bit frustrating, but that seems to be what works for us.
Thanks, David. On that subject of kind of the team all mucking in, something that we find with patient triage is that it is a change that impacts everyone in the practice, right? Receptionists in terms of maybe how they're answering the phones, the GPs in terms of the information they're getting before a consultation, whoever in the practice is triaging those requests. How have the team found it as a change? Is there any kind of challenges you faced and anything you did to help the rollout of it?
So everyone was used to it in a sense because we'd been using it, accuRx SMS and Flores and stuff like that during the pandemic. The receptionists were used to it because they'd sent invites out for flu clinic and things like that. And also a lot of our admin team had been using it to book COVID vaccinations and things as well. So in terms of having the toolbar and responding to things being in your inbox, I think everyone was kind of used to that. The hardest thing has been for the clinicians dealing with the queries coming in, I think. But it is just, I think if you've used any of the other products, it does feel very much like it's all from the same family, really. So it's quite intuitive, and we've tried to not involve everyone all at once. We've kind of assigned it. Someone had asked about a specific receptionist. I think that's a really good point. We always try to have 3 people at least that can do everything, because if you only have one person and they're off or on holiday or they leave, you're in a bit of a pickle. So we tend to have maybe 3 of our senior receptionists who would usually at least one of them be in, who if we assign, so for example, I get a a medical request that I've got a 4-week history of knee pain. That's the sort of thing I'm thinking that can be signposted to the first contact physio service. I don't want to phone them because I'm going to definitely need to deal with these ones. So I'm going to try and get our receptionist to care navigate that. We assign that to a reception team within the accuRx triage, and those 3 receptionists who have had the specific training about using it and who are conditioned to be looking at their accuRx inbox on the toolbar will pick that up and deal with that immediately. You can put a little note in there as well. One of the things we worried about is, well, it's a pooled list. There's 6 doctors in this day, and they'll all be working through. What if we tread on each other's toes? That happened the first couple of days we did it. One of my partners was phoning someone who I was sending an SMS to, and we thought this is terribly inefficient. So 2 ways around that. You can either say, one person say, David, I want you to do all of those accuRx queries. Can you deal with those this morning? Or if a couple of people are going to work through them, which might be necessary at a bigger practice, you can put a little note on there to say DC dealing with this one, and that's visible to all the global viewers. So your mate isn't going to come along and start trying to deal with the same thing, because that's quite frustrating. There's enough work without trying to duplicate it. So yeah, I think everyone's acclimatized to the change quite well. I think the receptionists really like it because the call volume has dropped significantly. The queuing times, I mean, it's still an issue between 8 and 9 because we could get 20 receptionists in and there wouldn't be enough to meet that initial demand at the beginning of the day. But because people are waiting less, they're getting less abuse when people do pick up the phone. And when people are grumbling about it, it's very quick and easy to say, well, did you know about this service? You can try this next time. You don't have to queue. You know, I've said to a few people, you know, if you're tech savvy enough to go on Google reviews and write that, you're probably tech savvy enough to do this. There's no registration required. Just give it a go. And the vast majority of people who have given it a go have found it was actually nothing to be scared of, really easy to use, secure, and they've got a response on the same day and they've been dealt with and they've avoided the queues. So it's gone down really well across the team, really. I think everyone sees the value and sees that it's a tool that's hopefully making their life a bit easier.
Thank you. A couple of kind of clarifying questions on where you started as a practice. Did you use another online system before Patient Triage, or was this completely new to you?
So we used prior to having online triage, we were with EMIS. We're now with System 1. That's another change. We've just been it's been a year of change. We've changed clinical system. We've installed this and changed our telephone provider, the latter of which was the one that didn't go smoothly. Before this, we used EMIS Patient Access, so people could book an appointment, and we set it up so that you could book a triage appointment. So you could go on there on the morning. The slots are embargoed till 8 o'clock when the surgery opened. And as soon as the surgery opened, you could go on there, book an appointment on the triage list, and then someone would call you. But what you tended to get was limited information. People struggled to, a lot of people seem to struggle to sign up for patient access as well. And we found that even people who are fairly, competent just found it was a barrier to accessing it. It just seemed like a bit of a faff. They knew they could come up and get a password and a login, and they'd have to show their ID. And I think people just never quite got round to it. They thought maybe I'll do that when I need it, but then when they needed it, they hadn't done it and it wasn't in place, so they ended up using the phone. So it's just so much superior to that in terms of functionality and the barriers to accessing it. We've had people we've had people, I think, up to the age of 100 sending in requests with proxies doing it for them. But we've had newborn babies up to 100. So it's there for everyone, really. Someone's asked about switching the tool off after 10. I mean, I'm quite an advocate now of, I think we've moved the bar. Initially, the fear was we can't turn it on, we can't put a link out, we can't share it with people, we'll be overrun. We've seen that hasn't happened. I'm trying to kind of now nudge people towards, why are we even turning it off? You know, we're saying we've got 3 working days as a safety net to respond to things. So why turn it off? And in fact, when I do leave it open, I see the volume of requests really tails off. So, you know, it's very much like a really steep curve between 8 and 9 that flattens off through the day, and they come in dribs and drabs. So in a sense, leaving it open from 10 till 6, I think you'd only get another 5 to 10 requests. That's been my experience. So I think it's fear of the unknown, and we're obviously all quite sensitive about managing workload and trying to kind of protect ourselves and protect our staff. But you're right. I think it's more efficient to deal with these. So I'd sooner someone submitted a request than called up at 5. And then by the time I've called them back, it's apparent they need to be seen. Well, that's kind of delayed me and kept me later than I need to be. Yeah, I think it's. I see Mike's question there about another lane on the motorway. That was an analogy that we definitely came up with. Yeah, so when I'm setting the sort of an idea of what I've got capacity wise on the day, I think about the number of cars that we're letting in, regardless of which lane they're in. So there's no point in doing 40 of these in addition to what you were doing on the phone, because you're gonna be overrun then. So we're nudging down what we would see as our telephone capacity as this rises. And as I said, now we're at about 60% phone, 40% accuRx. But the total numbers probably about 10% higher than they would have been, just because of the boost in efficiency. But they're static; they're not kind of increasing really, which is good for now until January. But we'll cross that bridge when we come to it, I guess.
We've had a question on, does Patient Triage automatically switch off on evenings, weekends, or bank holidays? Currently, there's an out-of-hours setting you can put on, where on evenings, weekends, and bank holidays, patients are advised it's out of hours and that they might not get a response. In terms of actually disabling it during that time, and that could be done with the set scheduled disable that will be coming soon. There was also a question on the integration with the NHS app. That's not currently available, but it's something that we're working on and prioritized, and we should have the integration within the first 3 months of 2022. That was all the questions, and I'm aware of time and I wanted to protect everyone's time on this. David, thank you so much for your time and for your sort of the detail and candid response you gave. I know I certainly found it extremely interesting, and hopefully people listening also found it really useful.
Oh, thank you. It's been fun to share. I mean, I think we've just found it's been really, really helpful. I think a lot of that, the biggest obstacle we had was getting everyone to buy into it, and there's always going to be people who are early adopters and people who are sort of laggards in that regard, but it's kind of meeting those. It's easy to convince the early adopters. You've got to kind of win the other people round, and I think what we tried to do was just support them and make sure that people weren't going to be sort of dropped in it, really. So some of our partners who don't like this way of working, we, rather than say you're going to have to, we've tried to kind of support them and accept that we've all got different skills. We don't all have to do the same share of the same work, I guess, which it's easy to say at a slightly larger practice, but that's the way we're trying to think about it. Our days don't all have to look the same. We can kind of play to everyone's strengths and weaknesses, and that reassurance might be helpful in getting people to buy in, I guess.
And if anyone has any sort of questions or would like to kind of chat with the accuRx team in more detail about anything that was covered today, you can always reach us on customer.success@accuRx.com, which will put you through to the customer success team on sort of implementing features that you have access to, where we know patient triage is the one that we get a lot of questions on. So thank you again, and wishing everyone happy holidays and kind of all the best.